What Hello from Mbantua country, home of the Aranda people, traditional custodians of the land upon which Alice Springs sits. My name is Donna Ah Chee and I'm the CEO at Central Australian Aboriginal Congress in Alice Springs. Congress is an Aboriginal community-controlled health service based in Alice Springs. We are one of the largest of such services in the country and one of the oldest. Next year marks the organisation's 50th birthday. As a way of reflecting on that milestone, today I'd like to give you a brief introduction to Congress, where we have come from, where we are now, what we have achieved, and what we might expect in the future. During this presentation, I will be drawing on some initial results from our Congress 50th History Project, which is being carried out by our research team based at Congress, led by Dr. Jocelyn Davies. Central Australian Aboriginal Congress was established in June 1973, when over 100 Aboriginal people from town and bush met to discuss the need to safeguard and promote the interests of Aboriginal people. Congress's aims were to be a voice for the Aboriginal people of Central Australia on all matters that concern them. It is worth taking a moment to reflect on the situation facing Aboriginal people in Central Australia at this time. Despite almost a century of colonisation at that point, Aboriginal language and culture were strong. Alcohol was not yet widely available, and family structures and responsibilities were largely intact. However, the physical conditions of our people's lives were very poor. The diverse groups that made up the Central Australian population has been dispossessed of their land, and in 1973, land rights were still in the future. Extreme poverty and lack of physical infrastructure had catastrophic effects on health, especially for children. In the mid-1960s, infant mortality in remote settlements in Central Australia was estimated at over 200 per 1,000 live births. That's 1/5 of children died in their first year of life. Health services to Aboriginal communities were limited. The hospital in Alice Springs was racially segregated until 1969. Wards set up aside for non-Aboriginal people stood half empty, while those for our people were overcrowded. These shocking conditions sound like a different world, but they are well within the memories and lived experience of many people in Central Australia today. Congress's first service was a tent program providing shelter to Aboriginal people living in living areas on the fringes of town. As time went by, other Aboriginal organisations grew to take care of issues like housing, education, and land. But health remained a great concern for our people, and in 1975, Congress started a medical service with the funding from the Australian government. A doctor was employed and transport and welfare services set up. This was the beginning of Congress as a primary healthcare service. Over the years, under the leadership of our community-elected board of Aboriginal directors, we grew and expanded our services, developing a comprehensive, culturally responsive and evidence-informed model of primary healthcare. But it was not an easy journey. For many years, we faced opposition and hostility from the Northern Territory government. It is worth remembering that for 23 years from self-government in 1978 until 2001, a series of country Liberal governments remained implacably hostile to Aboriginal rights, frequently representing those rights as a threat to the interests of non-Indigenous Territorians. Fortunately, those days are largely behind us. However, stemming from that meeting in 1973, speaking out for the rights and the health of our communities has remained part of the Congress DNA. It is an essential part of who we are. In the last 10 to 15 years, Congress has set up new services and programs with a particular focus on working upstream on the social determinants of health, especially early childhood. In addition to multidisciplinary primary clinical care and access to medicines, there are evidence-informed social and preventative programs in areas such as early childhood, maternal and child health, chronic disease, family support, and therapeutic interventions based on our psycho-biosocial 3 streams of care. There is also a strong cultural element, including male and female senior cultural lead positions, many language-speaking Aboriginal liaison officers, family support workers and community workers, and dedicated male and female health programs known as Nginja and Alukra. We have also expanded our footprint outside Alice Springs. The election of the first Labor government in the Northern Territory in 2001 opened the way for a more collaborative relationship with government, especially through the work of the Northern Territory Aboriginal Health Forum, which brings together key government agencies with our sector to plan, make policy, and advise on resource allocation. Through this process, a number of clinics formerly run by the Northern Territory Health Department have been transferred to Congress. Today, these include Ginjaporta, Endaria, Uchu, Mutijulu, and Amungana. This slide shows the program logic for Congress as we are today, developed in a joint research project with Professor Fran Baum and the former Southgate Institute. You probably can't read the detail here, but I think you will get a sense of the scale and complexity of Congress's service model and how we attempt to intervene at multiple points to both prevent and treat ill health at both the individual, population, and systems level. So in almost 50 years, what has Congress achieved? This is not an easy question to answer with absolute certainty. Not only is it difficult to measure health status changes consistently over long periods at a regional level by Aboriginality, but it is hard to assign any changes to any particular service, program, or even sector. We trust that the Congress History Project I mentioned before will provide some detailed evidence of our impact. But in the meantime, I would like to share some indicative ideas based on what we know from the statistics and our own long experience. This slide shows the years of life lost per 1,000 Aboriginal people in Central Australia from 1999 to 2018. You can see from the graph that there has been a significant improvement, especially for men, and especially for the period 1999 to 2013. There is no way to say without doubt that these gains are due to primary health care such as provided by Congress. In particular, the election of the first Labor government in the Northern Territory in 2001 led to a major increase in investment in public hospitals, increasing both their capacity and clinical safety. However, these years also coincided with a major increase in funding for Aboriginal primary health care from the Australian government following the relocation of responsibility for Aboriginal health into the Department of Health in response to much lobbying and advocacy by our sector. Under the Health Department's Primary Healthcare Access Program, announced in the 1999-2000 budget, investment in Aboriginal primary healthcare in Central Australia increased from between 330 and 1,500 per person to $1,500 to $2,000 per person. We estimate that the following expanding health services delivery initiative took that investment to a range between 2,500 and 3,500 per person. The late 1990s also saw policy decisions that allowed Aboriginal health services to access MBS payments and PBS Section 100 scheme that allowed remote area clinics to be reimbursed for medicines. This period therefore saw substantially increased funding of Aboriginal primary health care in Central Australia, and as a consequent increase in the size and range of programs that Congress was able to offer across the region. At the same time, there were no substantial improvements in the social determinants of health, like poverty, housing, education, etc. So we believe that these changes are a result of health service delivery in which Congress played a significant role. The next slide shows the number of alcohol-related hospitalisations in Alice Springs. Congress has been at the forefront of public and policy campaigns for evidence-based population-level approaches to restrict the supply of alcohol for many decades. This bore fruit in 2006 when the introduction of the Alice Springs Liquor Supply Plan and Alcohol Management Plan, which restricted availability of takeaway alcohol, especially 4 and 5 litre cask wines. In 2005, the head surgeon at Alice Springs Hospital publicly described Alice Springs as a stabbing capital of the world, and murders and manslaughter were at a terrible peak. The 2006 measures led to an 18% decline in per capita alcohol consumption and plateauing of hospital admissions, which had been increasing in line with other harm at the time. These restrictions were undermined by the introduction of cheap 2-litre cask wine from 2009, and consumption and harm went up again. Finally, from 2013, we saw the introduction of police on takeaway alcohol outlets, and this began the downward trend, although it was on again, off again, until late 2018 when it became permanent. This is the most effective supply reduction measures we have seen and is likely to have prevented many deaths. Unfortunately, with the loss of the Stronger Futures alcohol measures, much of these gains are now being reversed. The next slide I want to show you is the employment of Aboriginal people at Congress. Over almost half a century, Congress has successfully expanded from just a handful of staff to close to 500 employees, of whom almost 200 are Aboriginal. In addition, a third of our managers are Aboriginal. These staff are essential for delivering our culturally sensitive services. But also, jobs for Aboriginal community members contributes to closing the gap in the important social determinants relating to employment and freedom from poverty. Parental employment is key to lifting our children out of intergenerational poverty trap, as it is not only dramatically improves household income, but it also may be the key driver in getting our kids to school on a regular basis. So I hope that what I have described here today gives you a broad picture of the history and achievements of Central Australian Aboriginal Congress. Across Australia, there are close to 150 Aboriginal community-controlled health services, not all at the same scale as Congress, but all with their own unique histories and achievements for the health of the people they serve. So if there is a simple message I would like to leave you with today, it is this: Aboriginal community health services like Congress are self-determinant organisations by which our communities take their health into their own hands. They should be recognised and resourced as an essential part of the Australian health system and as the foundation for closing the gap in health for Australians First Nations. Thank you.